I tell you, one of the best moments in my long clinics are when I tell patients about complications. I'm talking about the ED part and retrograde, and the 84-year-old guys go, "That- I haven't had erection in like 10, 15 years." Okay. Okay. Next talk, I asked Nicole to come back up. And gee, I can't remember what the talk was on. I asked her to talk about all the different types of modalities we use and what laser settings are good and give us her opinion. Great. Thank you.
I will make one comment before Nicole starts.
Please.
I am really deliberate with this discussion with patients. You know, like Lori said, it like borderline weird sometimes, but I'm super deliberate. I'm like, there's erection, there's climax or orgasm, and there's ejaculation. We are not messing with the first two, but you're not going to have the third. And I do think the literature underreports it. I tell guys it's 100%.
Yeah, and I say side effect and the reason I say side effect and not complication is because the vast majority of these men have been on alpha blockers. A lot of them are going to have already had it. And you just have to explain what you have on your alpha blocker is probably what you're going to have after surgery. True. Yeah. I mean, I think the terminology matters actually. Because people think complications is a super bad thing that could have been avoided. True.
And it's shocking how many guys do not remember the discussion.
Yes.
I mean, they get it in written form. I talk about it. We talk about it in the pre-op area. I don't remember that at all. It's very common. So just be prepared that probably 15% at least anecdotally be like, we never talked about this.
And the other point, of course, is that if you look at the population that we're dealing with, and I'm looking at the randomized trial from the water study, the shim score at baseline was 13.7 in the aquablation arm and 13.2 in the TURP arm. So these aren't the same men as at the Minnesota Fair. These men couldn't have sex if you paid them. So yeah, that's
some of
to
them may
start
be
with.
paying
So
to try.
the whole question about ejaculation is rather moot for most of them.
Well, that was fun, Lori. It's so hard to follow that, I have to say. Smita was my fellow, so I feel connected there. Okay, so again, I do have a consulting agreement with Boston Scientific. I'm going to talk about Moses holmium pulse modulation, so that's a relevant disclosure. Okay, so we spent a lot of time today talking about endoscopic enucleation is what I'm going to call it generally, since we're talking about different energies. But I would say, like when there's sort of been a global trend upward as we started in the adoption of enucleation, as we started to talk about using different types of energies. And I'm giving you the long list of potential, and there's probably more that aren't on here. And so this has led to the concept that enucleation is all the same. It doesn't matter what energy you use. And so the terminology really, instead of saying HoLEP, THULEP, now generally we say endoscopic or anatomic endoscopic enucleation of the prostate more sort of broadly. And we've already spent some time today telling you this is the enucleation, particularly the reason why our guidelines say HoLEP and THULEP rather than endoscopic enucleation is because these are the two energies in which the most of the randomized trials have been done. And those are what the guidelines are created from. I'm showing you actually the European guidelines here. But again, the idea is it's level 1 evidence. And I think that's one of the things that's always frustrated me the most about the adoption of this, because if you presented this in any type of oncology presentation and there was level 1 evidence for a therapy, people would be doing it. So it's different, I guess, when Laura was saying this is a quality of life. And we've seen this point being here that size independent option for BPH. It's the only endoscopic enucleation is the only thing on the AUA guidelines that can be used for all size prostates. So let's talk here about lasers. Lori would be probably even better to have given this talk about lasers, but I'm going to just give it sort of down and dirty, as I call it, because I think it's important to understand when talking about different energies, their wavelength, particularly with regards to lasers, determines how they interact with the tissue. And whether they are a pulsed laser or a continuous laser, and how they're absorbed, whether by water or hemoglobin, also impacts how they interact with the tissue and whether they're better at incising tissue or vaporizing tissue, et cetera. So the holmium has a wavelength of about 2140 nanometers. It is a pulsed laser, has a depth of penetration of about 0.4 millimeters, and is absorbed by water. In contrast, the thulium YAG laser has a wavelength of about 2013, is a continuous laser. And so when you watch videos of thulium YAG interacting with the tissue, you get a very significant charring effect on the tissue because of this continuous, because of the wavelength and its continuous action. Yet its depth of penetration is actually typically considered to be about half of what you get with holmium, and is also absorbed by water. The thulium fiber laser can be pulsed or continuous. When you're using it for enucleation, it's typically in a pulsed laser action, has similar depth of penetration as the thulium YAG, and again is absorbed by water. So these are all, I think, they have a little bit of difference in how they interact with the tissue, as I talked about the charring and so forth that you can see with thulium YAG, but it's stark contrast to green light laser, which has typically been used for vaporization, has a wavelength of 532 nanometers continuous, and actually the depth of penetration could be up to, a centimeter. So, and then you have like coagulation depth past that. And the green light laser absorbed by hemoglobin. And then I think that there was some mention about that, diode lasers have been used. We haven't talked about them much at all, but diode lasers have been used. I'll show you a few studies. They come in different wavelengths, have a continuous laser action, and depth of penetration is much more significant. So 5 millimeters here. Okay. One quick slide about, everyone uses a little bit different laser setting, but with regards to holmium, I think 2 joules and 40 to 50 hertz works really well. I do turn the energy down near the apex of the prostate, anywhere near the sphincter. I'll go to 2 joules and 20 hertz. There are a number of publications, though, that have shown that you can do low-powered holmium enucleation. You can do it very safely. I just think it's potentially not as efficient. I will tell you, when you're on your learning curve, especially if you're using Moses, I actually turn the energy down for our trainees to 2 joules and 30 hertz, because if you're not used to moving the fiber quickly, you may find actually that the energy delivery is more than you want. And if you keep firing the laser, the depth of penetration will be all the way through the capsule. So it's important that you keep moving the fiber. The TFL is... I'm going to compare these two a little bit later. That's why I'm focusing on them. But TFL actually, when we treat stones, we say always stay in short pulse for TFL. Because even the shortest pulse in the thulium fiber laser is longer than the longest pulse in holmium. But for doing enucleation, you want to use 1 joule and 60 hertz short pulse for the enucleation, and then for hemostasis, you'll actually go to the long pulse, because you want something that's quite long. Like Casey said, he likes to use long pulse in holmium for hemostasis, something that is going to be more likely to be able to affect those vessels. So this was a nice meta-analysis looking at holmium versus thulium YAG laser enucleation. And I think, as I said to you, these are the 2 energies for which the most data is available. And I think they're really comparable in terms of the functional outcomes. and their safety. This particular study said there may be some minor advantages for blood loss and transient incontinence in the thulium YAG group. However, they also said that should be interpreted with caution owing to the low certainty of evidence. Well, let's talk about pulse modulation. So keep saying Moses, but what is that? Okay, so Moses technology, here you're looking at a normal, typical, standard Holmium laser pulse. One vapor bubble. You can see how far the energy travels by the red line. The pulse modulation that's been developed for BPH surgery, which is different than stones, actually. You're having this double vapor bubble phenomenon. The idea is that the first will spread the fluid in front, and the second will then travel through that tunnel and then be able to affect better energy delivery to the target. And what I would say is if I could pick one thing that I feel like has had the most impact on my own practice, it was the development of Moses pulse modulation or Holmium pulse modulation. I wasn't a believer at yet, and so we decided to do, once we had it, we decided to do prospective double-blind randomized trial. So every patient, it was me and my fellow Nick Cavus, and we did it the same way every time. He did one load. I wanted to see if this would, from a learning perspective, it would have any benefit. So I wanted it to really be applicable, not just sort of in expert hands or someone who's done a lot of cases, whether I'm expert or not, done a lot of cases, and whether or not it had any impact on the outcomes. And what we were able to show is that we were able to save about 20 minutes by using the Moses technology. And that was mostly not because it necessarily made the enucleation any faster, but it made the hemostasis faster. So that was where we really saw the major improvement. And I'm showing you some video here. What I would tell you that I notice with my, clinically with my eyes when I'm using the Moses, especially at the end when you're using it for hemostasis, is the energy just seems to spread out over a larger surface area. And so all those really small vessels that you're trying to coagulate at the end or before you're trying to morcellate, I think it really has a benefit there. And this has been shown by other investigators. The Moses BPH, we call Moses 2.0, which is different than what we used for our study. We used the Moses 1.0. The pulse has been modulated even more to better tissue effect. But in a retrospective study looking at Moses 2.0 to standard Holmium, the Moses 2.0 was also shown to have shorter hemostasis time. And it was based on that data, and actually this happened in my own practice, that I started to send patients home same day. It was the first time I felt like I could actually do that and someone wouldn't need CBI overnight. This was also shown in a follow-up randomized trial where one lobe was treated with Moses and the other lobe was treated with standard. And the Moses side had a shorter enucleation time and better enucleation efficiency. And again, another sort of systematic review and meta-analysis, just confirming what I've said about Moses, is that the hemostasis is better, which I think is what leads to the shorter operative time. In this case, it was found that the enucleation time is shorter also. That may be because of the peak pressure being able to open the plane really nicely, and we can talk about why I think, in my opinion, there is a difference in energies and why Holmium is best. But I'm just showing you the data here on the use of Moses technology. Well, Amy Krambeck's group was able to show that they could successfully send home 87% of their patients. And for the ones that they felt they would need to bring in, so a planned admission, those were the patients that were older in age, were sicker, so higher ASA scores, or were on anticoagulations, or their case time went long. So these are the patients who would have to come in. If you had an unplanned admission, it was mostly that you had a higher rate of needing a bedside irrigation. And this is one of the things I'll tell my trainees, like, do not irrigate the patients in the recovery room unless you are sure that the catheter is not draining. because once you start irrigating and fumbling around in there, you can actually stir up bleeding that was never there in the first place. Sometimes what the patient's describing is a bladder spasm, and so you just need to not fool with the catheter if it's really draining properly. They were actually also able to show that there was cost savings associated with using the Moses. If you use the Moses group and the patients used the Moses laser and the patients went home the same day, you had $840 cost savings, which certainly hospitals appreciate. Well, let's turn a little bit and talk about thulium fiber laser. I'm not going to talk about thulium YAG laser because I think it's been around a really long time. Anyone who started and this is my opinion, anyone who started in holmium never goes to thulium. It's people who are doing thulium YAG are the ones that learned using it. And there are places where it's very popular, like Germany. But the thulium fiber laser has gotten a lot of press recently, I think a lot with regards to stone, but then there are tissue applications like en bloc resection of bladder tumors, like upper tract urothelial. And so, trying to expand the tissue applications of this laser. So in this particular study, there were 52 patients who had thulium fiber enucleation versus TURP. When you bring out any new technology, you'll see in BPH, it's often compared to TURP as the conventional gold standard. And then this was 60 cc prostates. In this particular study, they found that the surgical time was longer for the thulium fiber enucleation, but the catheterization and hospital stays were less for laser enucleation, which I don't think is surprising. Also, the PSA was lower, suggesting that you took out more tissue is more effective. And as far as changes in hemoglobin and serum sodium were also less in the thulium fiber group. Really no difference in functional outcomes and or urinary incontinence. Well, what about Moses pulse modulation? So Moses HoLEP versus thulium fiber, because I think that's really where if you hear conferences so forth talking about this is the conversation, which is better. It's not thulium YAG versus holmium pulse modulation. It's thulium fiber laser versus Moses pulse modulation. And in this study, prostate's about 100 cc's, a little over that. Really, the Moses was felt to be better in enucleation, hemostasis, and morcellation time. But as far as functional outcomes go, they were very, very similar. And more patients in this Moses group had same-day trial void. Now, these numbers are quite small. There were only 20 in the thulium fiber group versus 62 in the, so it's a small study, but nevertheless comparative. Well, I'd be remiss if I didn't talk a little bit about the other laser energies. I'll disclose I have no experience using green light for enucleation. I did do some vaporization when I was a fellow. I think this seems very hard to do. Is there anyone in the audience has any experience using green light for enucleation? It's a side fire laser. I think that's part of why I think it would, in my opinion, it would be hard. And I expect, I'm showing you the technique here, but I expect oftentimes this becomes like a combination enucleation vaporization procedure. But when this was looked at in a single institution series, they did feel like the en bloc green lip was comparable to laser enucleation, at least when looking at prostates of 80 cc's. This is an interesting paper that looked at operative times of aquablation, green light, thulium enucleation, green light enucleation, and HoLEP. And not surprisingly, procedure time was related to prostate size, but really the highest procedure time was for PVP. And I think we talked a little bit about that. Dr. Gilling certainly alluded to the fact that it's potentially not very efficient if, when you're doing a large gland, especially, you could go through multiple fibers, and it's just not very aesthetically pleasing, I think were his words. But the laser enucleations were all pretty comparable in terms of their operative time. And when you just looked at the time of that, like, for example, that the water jets were going for aquablation, that was going to be the shortest. Well, we'd also be remiss if I didn't mention you can use non-laser energy. You can use bipolar. It is used in a lot of areas of the world. Remember, this equipment is readily available. And I think in that sense, I'm a proponent of the enucleation is a nucleation. I would rather you do a enucleation with the bipolar if that's all you have, rather than do a TERP that might not be quite as good. So I do think the caveat to bipolar enucleation is size. I think the larger the prostate gets, the more you do this. And I know Dr. Gilling has done bipolar enucleation, so he may have. In a prospective randomized trial looking at HoLEP versus patients had about 60 cc prostates. HoLEP resulted in shorter enucleation time, operative time, and enucleation. And there really no difference in I don't know anyone who's using. There are papers, diode lasers have compared diode bipolar. You know, the feeling is versus using bipolar seems to be better hemostasis, reduced catheter time, at least in one of these studies, but pretty comparable in the other that compared them. And then thulium YAG versus plasma kinetic or a bipolar enucleation, again, seemed to favor the laser group, less bleeding and shorter catheterization time. Well, what about the patients that are anticoagulated on antiplatelet therapy? I just thought this was a nice study that looked at doing HoLEP versus bipolar enucleation. And I think the take-home point is here that lasers are really going to be your best choice in the anticoagulated patients. Postoperative complications were pretty, were higher in the groups that were on antiplatelet or anticoagulation, but you could do both procedures safely, but I do think lasers do a better job. This was just comparing HoLEP, THULEP, DILEP, bipolar, and TERP. 31 studies, over 4,000 patients, showing that HoLEP had less risk of blood transfusion. And that when you compared bipolar to diode or HoLEP to diode, you had better, at least avoiding Qmax was higher in those groups, but all the enucleation techniques were superior to TURP. So I said to you before, like, I am giving this talk, energy is energy is energy, but I don't actually believe that. I believe that holmium is the best. I think Moses pulse modulation is a game changer, at least it was in my practice, and here's my case on which I would bring that, conclusion, or I made that conclusion. So this is a guy who came to me, right flank pain, gross hematuria, difficulty urinating. He was actually transferred into our hospital because they had attempted to put in a ureteral stent. You can see, hopefully you can see, these very large bladder stones, ureteral stones bilaterally, and massively enlarged prostate. He's obstructed. So, the question is, what do? You're going to put a nephrostomy tube. It might temporize. This guy's had clot retention, so they abort the procedure. He gets transferred to Vanderbilt. He's stabilized, and then I did a enucleation, assisted lithotripsy, and bilateral uteroscopy. And I have a case coming up on Thursday, same exact mirror image of this. So that's my case for holmium, because it is a very good multimodal laser. And this was a study published by Amy Kremek's group, just showing you that you can combine HoLEP with cystolithopexy, ureteroscopy, PCNL, TURBT. You really can safely do concomitant procedures using this technology. So take-home message, I am in agreement. I think enucleation of the prostate is the gold standard for BPH, has the best available evidence. I think if you look at the data, HoLEP and thulium YAG enucleation are best studied and are really very comparable, but I do feel as if, particularly from a learning perspective, I do think that, as I showed you in that very first video, you can actually use the holmium in a non-contact mode. We were talking about this before, and it will actually open the plane for you. So I feel like that's really quite helpful when you're learning. The data is pretty early for thulium fiber laser, but I would tell you in my own experience, I have both lasers at our outpatient surgery center, and what bugs me about the TFL is it like drags through the tissue. It doesn't open things. So you have to be very, like the working distance you're at, how you apply it to the tissue, et cetera, is really quite different. And if you only have bipolar, use it. I mean, I think that we have to be sort of open-minded when it comes to that. I would rather see the enucleation done than not if it's the right thing for the patient. And I think the holmium is the most versatile. Certainly you can use TFL for stones, but I actually like holmium for bladder stones much better than TFL as well. So that's the end of my talk. I'm happy to take any questions. Hopefully I didn't run over too much. Okay, good. The laser maven.
When I'm in Malawi, I use a button for, so I like the button better than the loop for enucleating. I just find that I can use the button to get right into that plane and just push it forward and can be pretty efficient. So in my hands anyways, using that for bipolar. In Boston, there are a couple people who use the ProLeave diode. So diodes are not all diodes. So that's part of the problem. Like some of these publications are from a number of different diodes.
Mm-hmm.
Some diodes have more of a hemoglobin effect than a water effect. ProLeave is more water than it is hemoglobin. And so I do see that one used a bit more and probably a little bit better hemostasis just because of the hemoglobin effect, but more char. You also get more char. And I also have tried to do the TFL enucleation. I don't know what I think yet. I mean, we have both lasers, so if someone else is using the holmium, I'll use the TFL. I'm not Naeem, that's for sure. I can't find whatever plane he seems to find, but it gets the job done, and the patients do well. But it doesn't look as pretty. And there's definitely more charring and more blanching of the tissue. So.
Naeem always says, I use the TFL because I don't have Moses. That's what he says, I swear. He only has standard holmium. He likes TFL better than standard holmium.
So I mentioned earlier, we kind of gone through the process in the last 18 months of trying every thulium fiber-based system that is currently available. And in my opinion, they are all inferior to holmium, especially for learners. They require more mechanical work to maintain the capsule because you don't get that high peak energy that pops the plane open. The other thing is I may be doing things different than Naeem, but there is, again, anecdotal. We experienced a relatively significant percentage of those patients coming back with bleeding around 5 to 9 days afterwards, particularly with the store's new laser. The one laser that we don't really cover is the Thulio, which is that new pulsed
I don't know if
thulium
there's much
YAG.
data for it.
There's
That's
none.
why I didn't.
Yeah, there's none. There's no comparative data.
Yeah.
But in in my hands, it is the closest to holmium.
Mm-hmm.
It's definitely appealing that it's this like box that's the same size as my laptop. It's like this tall.
Mm-hmm.
It plugs into a regular outlet. So it's very quiet. It's spookily quiet compared to. Yeah.
Air cooled, yeah.
Right. But very similar to holmium in tissue effect.
Thank you.
All right, our next speaker is Mike Phung. Mike, if you haven't figured out from him talking with Joel, trained with Joel in Arizona. He then went to LA and did a fellowship so he could be a card-carrying endourologist. Ultimately, to go and work with San at Kaiser, Southern California at Panorama City. And I asked him to talk about complications and things that we can do to minimize complications.
All right. Well, thank you very much, Sean, for inviting me, and Sam for letting me tag along. I feel wholly unqualified to be up here following the Godfathers right there. I mean, Peter Killing, we were hearing about him from Joel when I was a resident, be like, New Zealand, what? But this is quite an honor to let me share my experience. So I wanted to talk about what I do to prevent bleeding when it comes to HoLEP. I don't have a PA, I don't have a resident, and so I like my census to be as close to 0 as possible. So I do everything I can to get them home the same day and not have to round on them. So yeah, that's what I do. I have no disclosures. So I really like this quote. I've never read the whole book, but I think this lesson is good for the HoLEPs and surgery and everything I do in life. I mean, every battle is, well, won before it's ever fought. It's missing a word there, sorry. But it's all about pre-op evaluation, right? Whatever you can do to minimize your risk intraoperatively, you got to do. And sometimes you have a patient who needs a surgery, and you had to be giving them the hard and long conversation of whether they're fit for the surgery. And so, at least when it comes to bleeding, things that I look out for when I counsel these patients, their risk, what to expect after the surgery. One is, a large prostate size, more than 150 grams. Whether or not they had some sort of underlying malignancy and they're on active surveillance, those patients seem to bleed more. Patients who had a history of chronic catheterizations or UTIs seem to bleed a lot more. And obviously the big one is anticoagulation, patients with AFib, cardiac stents, and whatnot. When it comes to anticoagulation, obviously there's a whole gamut of them out there now. And they all have different pharmacokinetics and how long you need to keep them off of them. When I talk to my patients about it, I always say, they're on anticoagulation for a reason. And some patients don't want to come off of it. They come off at once, or they had another stroke, and that's something that I talk to them about and they have to consider. But for the most part, I get them off if I safely can. If I can't, then I talk about doing it with them on it and the higher risk of requiring CBI, transfusions, and whatnot. But overall, it's still, the beauty of the HoLEP is that the overall risk of transfusion is still quite low. And even when they're on blood thinners, so obviously it's always ideal to avoid it. As San had discussed earlier too, with the giant prostate artery embolization before the surgery could be helpful to minimize the risk for bleeding and transfusion. And for some of these patients who are on anticoagulation, who are quite unhealthy, sometimes that's all I can safely offer to them without going into the risk of mortality. And so that is part of my discussion with all these patients who are not healthy, who are anticoagulated, and what can we do for them in terms of treatment. So I really like this table from JAMA. It's a great survey of the blood thinners and how long you should keep them on first off. Obviously, I think everyone kind of has their own little voodoo ways of how long they want them to be on blood thinners and how long to keep them off of it. Overall, with a lot of the NOACs, for the most part, you stop it about 2 days before the surgery. That's the literature. That's what I've been steering more towards, is stopping at 2 days beforehand. In the past, I've been more cautious, especially when I was out doing my first set, to have them come off 5 days beforehand or more. But now I routinely just have them stop about 2 days before the surgery. And the real question mark is how long you keep them off of it, right? Some of these patients look great, and then all of a sudden they don't. So I usually counsel the patients that about 48 to 72 hours afterwards, if the urine is pretty yellow, and the hematuria is minimal, I'll have them restart it. But I also tell them that this could be a game of whack-a-mole in a way. You'll be taking it, you'll be starting it, and then you'll have some bleeding. at that point, I tell them to hold it again for another 24 hours, and then it could be several weeks before that it all clears up, and that's something that they have to accept and be cognizant of. When it comes to other blood thinners, I mean, really the one that freaks me out the most when I see on the list is Plavix. The only patients I've had who've had really significant bleeding, a few weeks after the surgery, were on Plavix. I'm not sure what it is about it, but those patients, when they restarted, they seemed to have much more bleeding, at least anecdotally in my experience. For those patients, I do monitor them a little bit more closely. With warfarin, I had them hold it 5 days prior to surgery and then 24, 48 hours afterwards, depending on how the urine is. I usually continue it, full strength aspirin, but I don't push it. I mean, haven't had too many issues with patients with aspirin, at least. All right, so interop, what do you do, right? I mean, you're in there, you're bleeding, and thought goes to your mind is like, why am I doing this? But for the most part, patients do great. The biggest thing is obviously knowing how to use your laser. The laser is very hemostatic, but you have to be precise with it, and you have to know what settings to use. I'm a big fan of when I'm like going through and seeing a large bleeder is turning down the energy and lowering the frequency. If it's a small bleeder, I'll sometimes go at 1.5 and 30, and especially at the end, if I'm just kind of trying to get the clot off, just kind of do get some hemostasis before I do the morcellation. I'll do 1.5 and 30 and blanch the fossa. But if I see a very large vessel, something that's like the size of my arm, I'll turn it down as much as I can, because what you don't want to do is end up chasing it too far out. I had some scary instances where your laser energy is too high, and you're laying it on there, and the bleeder just keeps getting further and further away. It's retracting in the capsule, and the last thing I want to do is go through the capsule or lose the bleeder. And so I found that turning down the energy to 1 in 20, at least in my experience, that's works best for me. Does a pretty good job of getting hemostasis. And letting the laser do the work. You have to be patient with it. There are some bleeders that are just very, very stubborn. And the last thing we want to do is rush through it. Because when we start dealing with very large prostates, you have a very large surface area that can bleed, obviously. And so just like people keep saying, pay as you go, it really does pay dividends later on. Last thing you want to do is enucleate it, and then you push it in, and now you just see red everywhere. Especially when you pop in the adenoma at the very last second. When what I usually do is I usually do most of my HoLEPs in block. I'll nucleate it, and then at the end I'll pop it in and keep it attached to the bladder neck. And every time I pop it in, it's always a lot more bloody than it was before I popped it in. And I think that has to do with kind of the compression of the adenoma, different fluid dynamics of that area. And if you didn't do a good job taking care of those bleeders, it could be a real pain in the butt to see what's going on, and then you're chasing those bleeders again. And then pulse modulation, if you have it, I will say that Sam and I do not have Moses, but we're still able to get most of these patients home the same day. Even during residency, I mean, Joel and I didn't see a Moses. I had no idea what P120 was until my chief resident year. But we still were able to get the vast majority of patients home. It does take longer, if you're just using pure laser to get the hemostasis. You have to be more patient with it, but it is very doable. But obviously, if you have Moses, you have virtual basket, definitely take advantage of it if you can. And when it comes to anatomy, obviously the part of it is knowing where the bleeders would be. The prostates supply the inferior vesical artery, and it branches twice. And the big areas for bleeding are going to be at your bladder neck and then towards your apex near the viru. That's where the major arterial supplies are. The other thing to keep in mind too is those blood vessels don't just come and end on. A lot of times they wrap around circumferentially. And so you can sometimes end up through the same bleeder twice. And so in those patients, you just have to be cognizant that, especially interiorly, I've noticed, those blood vessels interiorly usually they're very large, they come right like this. And if you get in, it can be really difficult to see, especially in a large prostate, and you're trying to drop your hand really to even get the angle up there. And for those patients with large prostates too, I try to be as hemostatic as possible anteriorly. because once that adenoma is no longer in the fossa, it can be really hard to reach that anterior neck because there's nothing holding you up anymore. And then you really have to drop your hands, and sometimes you're like, feels like you're 10 feet away and you have to advance the laser forward because you can't get the angle to quite get it end on. And then finally, are you too deep? Another thing that can happen too is you're not on the right plane. And when those bleeders are coming in, one of the things I think about is, am I too deep? Because if you're in the right plane, typically you're not going to see a whole bunch of bleeders, at least not in the peripheral zone, or sorry, the posterior zone or the lateral areas. But if you are getting out of the capsule, you can start to see some really, really large vessels. So there's some intra-op video here of what I do. So the first step is obviously, you run in the bleeder and you can see it. There are times when you really can't see the blood vessel very well. So for those patients, I try to get the adenoma out of the way. And the other thing too is sometimes if you can't get the bleeder end on, you can see where the vessel leading to the bleeder is. And for those patients, I'll actually get away from the actual bleeder itself and blanch the area. And that does a pretty good job typically of controlling it. Because sometimes you just can't get the angle when the artery is coming in at a 90-degree angle and your laser's coming like this, you're not gonna get the angle to hit the bleeder end on. And so you have to see sometimes where it is coming in, feeding it, and you can blanch that vessel, and that usually does a pretty good job of taking care of that bleeder. The other thing too is, again, modulating your laser distance. If your laser is too close, you'll just bust at the capsule, it'll just keep bleeding, and you're just gonna be chasing it. And so one technique I learned with Joel was staying off the vessel and really sneaking in on it. Advancing it slowly until you get that sweet spot where the bleeding is stopping, and you just sit on it for an extra second or two, and you lay off and you see if it stops. And sometimes it takes a few tries to really get that vessel sealed up, but you definitely want to take care of it. Another thing that I found to be helpful too is sometimes if you've got a big spray of artery in your face is to, plug it. Okay, so I will tamponade it with my laser element. And that does one of two things. One is it lets you kind of make sure you're on the vessel, you know where it is. And two, it gives you time to think, because sometimes when you see a big red out and you don't quite know where the bleeder is, it can be, really alarming. But allowing it to tamponade off lets you time to think, lets you kind of think about in your head, like, hey, how do I want to approach this? Can I see the feeding vessel? And lets you kind of slow down. I mean, at the end of the day, a lot of HoLEP is taking your time, being patient, like they were saying earlier, slow, smooth, or smooth is slow, smooth is fast, whatever that quote is, but I'm like getting tongue-tied up here, but yeah, taking your time, paying as you go. Other area that has quite a lot of bleeding too, again, is the bladder neck. And again, the theme of the day is slowing down. Here, I truly try to slow down here because, again, some of those vessels, they can be really hard to reach later on in the case. And so I typically, if I start seeing really large vessels, I will prematurely bring down that laser setting down to like 1.5 and 30 or 2 and 20 or even 1 and 20 if I'm really seeing large vessels. A lot of those vessels especially will come in towards the sides, more like 10 and 2 and sometimes 5 and 7. And so those cases I'll nucleate through until I can see the vessel, and then I'll turn the laser setting down and then cauterize them. Because it's just, you just don't want to get into it later on. I like taking care of it when I can see it. And again, you can see there, anteriorly, there's a vessel that comes out, wraps around anteriorly twice, and you just got to take your time to take care of that. Another thing, too, is avoiding to cut too lateral, because, again, those are where the large vessels are. And also, besides bleeding, I found that you can get the calves could be thinnest there, at least in my experience, and that can lead to urinary extravasation. I've had maybe 2 patients I can think of where that happened, and And those are patients who got bladder neck contracture. I don't quite see many bladder neck contractures, but those 2 patients, for sure, I probably, because I saw fat, you know. And so to stay in the capsule, avoiding getting out of the capsule will help keep you out of trouble, avoid complications. So like I was saying earlier, Sam and I do not have a Moses laser. And so in the past, I would just sit there for like 30 minutes and just cauterize the fossa with regular luminous 80 watt. But in order to save time and also for my own ability to sleep well at night, we take out the bipolar at the end. And we actually did trial the Moses laser. And we just couldn't justify the cost of the laser, buying a new laser, the laser fiber versus opening a bipolar element at the end. Time-wise, this takes me, 5 to 10 minutes. It looks incredibly clear, and I get the patient home. I guess you can make the argument that you can use Moses with stones as well, but we just weren't able to justify the cost differential of their luminous 80 watt with the P120 and the added cost of the Moses lasers. But what I do at the end of the case is, again, I'll empty the bladder, and then the first place I go to is the bladder neck. That mucosa, when it's empty, will come towards you. But once the bladder starts to fill, as the fossa starts to fill, that mucosa will start retracting away from you. And sometimes those vessels can be hard to get with the laser, especially if if those UIs are close to the bladder neck. I mean, it can be a place if you have a very large median lobe where the median lobe can creep in, where the UIs can be very close to the bladder neck. And so I try to stay away from that area. And so I will empty the bladder, I'll let the bleeders come towards me, and I'll cauterize the bladder neck. Another place where you can get a lot of bleeding too, again, is near the viru, apically, and at the cut edge where I'll make my early apical incision. Those are the other areas I'll spend a lot of time taking care of the bleeding. And this is how it should look at the end of the day. At least this is my goal every single time I do the case. I keep the flow really low, to the point where it's like basically just kind of half flow. Now, obviously, this is an ideal case. You can't always get this, but this is what I always strive for. It's in order to get the patient home and sleep better at night. So I'll put in my catheter. I'll flush it 2 or 3 times and as long as it's light pink, then I know I'm done. I'll start the CBI and I try to get as clear as possible. Now, there are some times where you do this, and then you start the CBI, and all of a sudden it's like bright red again. Luckily, that's pretty rare in between, but I do not end the case. I do not let them detach anything until I am very happy with how things are going. The last thing I want to do when I leave the OR is go back to the OR with the same patient. And so I always take my time in this step. Having to spend an extra 5 minutes going back in there and cauterizing stuff is a lot better than me talking to the patient's wife and be like, hey, sorry, but we gotta take him back. So I always take my time with this step. So there's some data out there that people are using TXA, the antifibrinolytic agent. People are giving a gram or so. I've used this once. I don't really think it made much of a difference. I guess if you're really in a pinch, you could try it, but you might be just better off praying like this person is for the waterfall, to be clear. You do? I've used it once, and I don't know. I mean, I didn't really notice a difference. Yeah.
And I find that with really big prostates, I often have to run the CBI longer. And when you're in an outpatient center, I have an hour and a half. They're
Right.
transferred up to the hospital or they're out. And so I can do a lot bigger prostates. The only caveat, in case you can say if you believe this or not, but the clot, if you do get bleeding, you get clot, the clot is very tenacious. So
sure.
Ordinarily, we don't care about the clot too much. Like maybe lasered off, try to get it into the bladder here. I do try to get it
Do you give it at the end of the case or beginning? Okay. And you give a gram, or what dosage do you give? Gram. Right.
They give it all oral now in the
Hmm.
preoperative holding area. They used to give it IV, and because their cases were longer, they'd have to dose it twice. But apparently, the bioavailability is pretty similar.
Onset action is 45 minutes and it lasts for about 3 to 4 hours.
Okay.
We used to give the PO, which is 1950 milligrams, but it's like horse pills. And so you've got old buddy that you're doing HoLEP on and he chokes on it one time and they're like, we can't do that anymore.
Right.
Now we give IV. It's also super cheap. It's not an expensive medication. I think that you laid out the contraindication. I'm a huge proponent for TXA. I use it in people that are consults for refractory hematuria for non-postoperative. I do buy the data for complex PCNL. I'm considering giving it preoperatively. There's never been a study that has shown, at least if you look at the large meta-analyses in the trauma and vascular surgery literature, that shows that it's associated with de novo venous thromboembolism, because you can think of confounding factors that
Right.
result in that. That being said, I've had patients who have had DVT, who have gotten TXA, but you know, I still think that it's a very uncommon event, and I find that it's really beneficial.
Okay. Well, might try it out sometime. Yeah. But I mean, right now, routinely, we do not use it, at least at our medical center. And then post-op, this is my routine. I'll have them run CBI in the PACU, kind of just open. If it's super clear, I'll have them just titrate it down and just run it to whatever rate they need it to be clear. And then I'll clamp it. We'll watch them, let them ambulate around. And if the urine is without any clots, it's red, you know, I would say about pink lemonade, maybe a little bit dark, maybe towards cranberry, I'm comfortable sending them home. Now, I think one of the biggest benefits, again, with the bipolar cautery, or at least just all the time we take at the end, you know, is it overkill? Possibly is, but it helps the patients, I think, feel better. I was telling I had one patient who emptied his Foley bag at home. He vagaled. They called 911, and they checked his labs, and it was as and his hemoglobin had zero change. But just the urine was enough to freak them out. Well, in this case, and so I think any the urine as clear as possible. Maybe I'll try that. It can be beneficial, even if it can help, you know, with patient anxiety, lower the phone calls, lower their urgent care visits, and that's something that we always obviously strive for. And then the Foley removal the next morning at home. We send a video of the patients. We just have them cut the balloon catheter. And, you know, knock on wood, usually goes pretty well. Obviously, so there's going to be some patients who are going to need more hand-holding, patients who are retaining already a liter beforehand, and you're not sure about their bladder function or overall. I'll have those patients come in, and my nurses will remove the catheter. For the most part, we've been pretty lucky with patients doing pretty well just removing the catheter at home themselves. You know, one caveat, well, not even a caveat, just kind of a tip, is avoiding too much distension during the morcellation and during the HoLEP. I have done a handful of same-day void trials. Honestly, I think it helps the patient a lot more than it helps me, in the sense that when it goes great, it's great. But I did have a couple patients have come in, they voided, they seemed like the past, and they ended up back in the ER in the middle of the night. And again, you know, anything I can do to prevent that, I try to. And so I have gone away from the same day void trials because, you know, 12 hours of the catheter, I think beats coming back in with an ER visit. So in summary, you know, knowing your patient, their comorbidities, their blood thinners, and counseling them on what their expectations would be. Knowing your laser, you know, what settings are optimal for the enucleation, for the hemostasis. Finding the right plane and sticking to it. You know, you don't want to get too deep because there's space. And then taking your time. It's a great goes well. They don't always, but you know, it's part of the. I think it's a great surgery. So thank you for your time.
I have a question really about the TXA because I don't use the TXA. For Nicole and Casey, when you use the TXA, do you also use it post-op? Like you send them home on it? Just single dose. So really it doesn't help them once they go home or if they're on antiplatelets. Do the ortho guys send them home with it or it's also just?
There's also like a 5-day Menaraja protocol that the guys use
Mhm.
that I've used for like scrotal surgery sometimes. I think it works.
So,
What's that protocol entail?
I think, I don't remember, maybe 250, I'll look it up. Say 16.
and then the other question is, if you use TXA, do you use any traction at all post-op?
My goal is to limit the use of traction. My goal is to limit the use of traction. My general protocol is I keep people 23 hours. If I'm going to send them home, I think my goal is to send them home with a same-day avoiding trial. I think that TXA definitely limits the amount of traction that I'm using. I'm not needing, mechanical. In fact, it's often me just kind of wimping out. I'm finishing a huge prostate at 5 o'clock. They're clear going to pack in. I'm like, just put them on a little bit of traction so the PAs don't have to do it at 7 o'clock, right?
Sure.
So I think that that's really helped with that and the people that you keep, because traction really drives a lot of the bother in the 15 hours they're in the hospital.
Right. Yeah, because the other thing I've noticed too is sometimes it seems like the bleeding is caused by bladder spasm. So anything I do to prevent bladder irritation, I think is helpful. I think one of the most annoying things in it's crystal clear, you're done, the patient wakes up, starts having a bladder spasm, and then the bleeding starts and the other thing I guess to take into account too is blood pressure control. It's also disheartening when you do a great case and they're waking up, the blood pressure jumps up to like 200, and then it looks like all hell's broken loose again. Yeah.
I really like your point of intermittently. I actually try hard not to empty the bladder completely until I'm really thinking I'm done, because
Right.
then you just end up chasing bleeding. But
Right.
as you're getting final hemostasis, shutting off your inflow and letting the passive outflow stay on so that you can identify small venous bleeders, I think no matter how you get hemostasis is a really good point. And another thing for people that are starting up who might have fluid management systems in the hospital, be very cautious if you use something like a Thermodex or something like that where you're getting a little bit higher pressure. A really close colleague, a co-fellow with me, Mike Borofsky, they were using one at Minnesota, and he had a rash of takebacks because he was completely not appreciating venous bleeders that he wasn't otherwise seeing with just a slight difference from your 1 meter height of your two TUR tubings and a system that might be pressurizing it, 20, 30 millimeters
Totally.
or centimeters of water. I don't either.
Found the oral regimen. So if there's 650 milligram pills, you take 2 of them, so 1,300 3 times a day for up to 5 days. Okay. So the TXA, like the Menaraja protocol is 1,300 milligrams oral 3 times a day for up to 5 days.
I don't use the TXA. I'm not aware that we've had any. The only takebacks I think that we've had are more about catheter placement and where the catheter is than it is what the bleeding is like at the end of
Flashing
the
back to
case.
residency, actually think about that.
It's either been placed below the bladder neck,
Right.
or the balloon's been inflated and it's too distal. And I agree that the Thermodex is, in my opinion, far less than ideal. That pressure sensor is not immediately responsive. Mike and I talked about those cases. You can't compensate for hemostasis with increasing the pressure. And there are cases that haven't been reported, but I know have occurred, of bladder rupture because that pressure sensor is not immediately accurate. And so, if you're running it at 80 or 100 on the Thermodex, that's not a good idea. We use a gravity-fed system with a Ranger tubing that has a warming bladder. It's at 42 degrees for every patient. And the staff like the gravity system better too. The Thermodex is very finicky. I mean, you use what you got to use. We got one because we were at a point where we couldn't get any Ranger tubing for like 4 or 5 months in COVID. So it's either you use a Thermodex or you don't do cases. So great presentation, Mike. I really would emphasize your point of being methodical about those big bleeders.
Right.
You know, everybody's immediate response, especially if you're coming from a different energy source, is I got to stop it. And so you're used to like, oh, I can just put a bipolar loop in the area code for the bleeder and it's going to stop. You need to have the phone number with the laser. You can't just, as I call it, you can't spray and pray.
Right.
You've got to, whether that is you tamponade it with the laser fiber. I think your point about is really critical of you've got to dissect the adenoma away from the bleeder, because a lot of times you'll encounter those right when you start to get to that point in the enucleation, and it's right at the junction.
Right.
And you just can't find it. It's like trying to run the Bovian sub-Q fat and hope that you get it stopped. Dissect the adenoma away, identify it. The other thing I think that's helpful sometimes is you can change the orientation of your scope, and that's where I will vary from my lens fiber capsule orientation. Just the fluid dynamics will change. If I rotate my scope around and try to invert or look at it differently, sometimes it'll get it so that it's blowing that arterial blood away from your scope, and you're like, oh, I can see it.
Right.
Yeah, just a confession. Mike and I use the Thermodex. And
Low pressure, 60 millimeters mercury.
yeah, and
Yeah.
I got to tell you, we love it. And you know, we every now and then, like I would turn it up to like around 90 if I'm kind of like in a small space and I just need some extra irrigation. Sometimes I forget actually to turn it down again, but you know, I think generally it's pretty safe if you keep it around 60. That's probably where it should be most of the time. But it's good to know that there's been some complications, and we have to be aware of that because you know, sometimes we forget we're just using it all the time. But yeah, I mean, I have to tell you, like it's there on every single one of our cases actually, and it's helped. Yeah.
I thought it was a really good talk too. Really helpful for me. Just in terms of kind of hemostasis at the end of the case.
Yeah.
I always feel like I go through the whole fossa and try to find every bleeder, and then when I look down, usually towards the apex on the contralateral side that I just work on, there's this blood clot that kind of covers a whole bunch of things.
Right,
and then I laser the blood clot to kind of move it away and do it again, and then I come back, and I don't necessarily know always what to do with that, 'cause sometimes there can be quite a bit. I mean, is that, do you leave it there? Do you?
I try to get all the clot out of the fossa. I used to leave it alone, but you know, I think that, and then I started changing to try and get every single clot out of the fossa more. And so what I do is I'll blow it all out of the fossa, and then I will keep with hemostasis throughout the whole fossa until there's no more clot accumulating. I'll keep doing until there's no more clot accumulating in the fossa, because I had a handful of cases where I think that, you know, there was still something going, you know, because it's clear and then it's not, right? I mean, and you just want to be as clear as possible. If you want to sleep at night, I got 2 kids at home. The last thing I need is to be paged, you know, it's like, so I will do everything I can to make sure it's clear. So I'll get all the clot out of the fossa. I will take a look at the bladder neck, I take a look anteriorly, and the vira. Those are the 3 places I always look. A place that I think I overlook at times though is that cut edge, you know, where the mucosal strip was, where you took it down, because that can bleed too. And so I'll take my time. I'll do as much as I can until I feel very comfortable that I'm done. Because, you know, obviously everyone here, I'm sure, has been experienced where, I think it's going to be okay. It's usually not okay, you know? And so I think you need to optimize that. The other thing too is again, you know, turning down the inflow and keep your outflow open. That I think is very helpful in terms of the little, you know, because sometimes it's not a big bleeder, it's just a bunch of small little bleeders, right? And so what I'll do then is I will turn my outflow on, and I'll turn the inflow to basically 0. I'll just kind of give it little squirts. And then when you do that, you can sometimes see where the streaming is coming from. and then I will laser those low bleeders end on, or I'll bipolar or whatever. But yeah, you just kind of, just like Joel said, a lot of patience, being methodical about it, because you don't want to go back, obviously. Great, thank you.
We are coming to the end, and I'm tempted to just say thank you, but I'm going to pick on the panelists and ask a few questions. Can we bring up the last slide set? All right. We went through some of this, so I'm going to skip this. Irrigation, we just went through this. For the speakers, do you all routinely use Lasix at 1 hour? Anyone do that anymore? For fluid absorption? No? Peter? No? Okay.
It's a good number. Like Amy published that data subsequent to your residency, so I gave it up.
They put all absorption studies back in the mid-90s, and there was a wide variation up to a litre of fluid.
Right.
Never came to publication presented in the AUA, but I would, if the procedure is prolonged, certainly after a couple of hours, I would certainly consider it, and someone who might not benefit from an extra couple of litres on board.
All right. Management of anticoag, antiplatelet therapy. Again, for the speakers, how many of you have patients just maintain on the anticoag, antiplatelet throughout the whole treatment without stopping it? Does anyone stop it? Yeah, pre-op. But Joel, you keep them on? What's your experience?
I succumb to peer pressure, and I don't stop it anymore. Before we had, maybe it's just an excuse, but before we had a 2.0 system, I would do what Mike described. When we got the 2.0, I finally was like, all right, we're going to take the leap, and we keep them on full anticoagulation. And we will still do that. I don't do any same day voiding trials. I don't have the PACU space for that, but we still will do post-op day 1 cath removal. And I just tell them you're probably going to have hematuria for 14 days instead of 7. Yeah, I don't mess with it anymore. Makes my life with the cardiologist easier.
Yeah. Where I find bleeding is worse is when they restart the anticoag. That's the problem time.
Mike remembers, we used to be like, you'd stop it 2 days before, if they're on apixaban, or, 5 days before. I didn't worry about warfarin, but it's the antiplatelet stuff that really bothered us. Restart it when your hematuria goes away. It's going to come back in 48 hours. As long as you don't have clots, stay on it. If you have clots, stop it again and repeat that process. And our experience is like yours, which is a lot of times it comes back and they've got to have this fits and starts. And I think with 2.0, I've given it all up. Groundlink and Manicus were like, you just got to start doing it. I don't do TXA at all, and I don't do traction either.
How about antibiotics? What do you
AUA
guys-
white paper, 20 urine culture. If it's negative, 24 hours, they get a perioperative dose.
What's
That's
your choice of antibiotics? Gent?
Ansef.
Ansef.
If they have a catheter and they've gotten a culture, we've done culture-directed therapy through the time of surgery. If they've, sometimes they screw up their culture and get it done 2 or 3 weeks early. Try to get a testicure just to make sure they're still clear. But for the guy who doesn't have a catheter, it's a single dose of Ansef.
So how many days of antibiotics do you give someone who has a catheter, mixed culture, etc.?
We usually do our pre-op culture about 10 days, so I get it back probably day 7, and usually give them 10 days. So they've got 3 post-op days.
I give 5 days. I don't know if there's any good data.
There's no
I give
data.
5 days.
Yeah, there's no data, so that's why I just listened to the AUA who says that first generation cephalosporin is fine for TURP.
And talking about same-day discharge, how many send people home routinely post-HoLEP? Okay, and then do you have any size restrictions or any parameters that you use, or it's just the case went well, send them home?
How far will they live from my office?
Okay,
If they don't want to drive back the next day for their voiding trial.
sure.
I mean, I'm referral practice, so those people just stay in a hotel that night, and we set that up. A lot of them will also meet them on Tuesday and operate on them on Wednesday or Thursday, and they stay and then fly home.
We finally have a nice hotel close enough. But we'll do the same thing that Nicole does. Like if I've got somebody coming from out of town, they're always a Thursday case. So I'll see them on Monday. We'll do their case on Thursday. They'll either stay in a hotel or overnight in a hotel banner. And then I'm okay with them flying home on Sunday. So they're in town for 7 days. I try not to have them make multiple trips.
Now, when the same-day discharge first came out, there were reports of like readmissions coming back to the ED on the order of like 25% or more. What is your experience now with that?
Well, I mean, our data was not that. Our data was the readmission rate, and at the time we were doing ECOG as our basis primarily. So, anybody who was an ECOG 2 stayed. So inherently, those patients are going to have a higher readmission rate because they've got, they're medically complicated. But our readmission rate with our same day non-pulse modulated patients was no higher than if they stayed home. Their 30-day readmission rate if they stayed overnight. Excuse me.
Nicole?
Yeah, I mean, I think going back to your other question, do I have like size? So if they're like 200, 250 with a catheter in, I find that they may need CBI longer than an hour and a half, and that's I have to make those choices. I have no way to like observe them overnight in our outpatient center. So I'll put them at the hospital. It doesn't mean that they'll definitely stay overnight, but it gives me the opportunity to sort of observe the CBI longer. But I think if we select correctly, I can't think of anyone that we've like transferred from the outpatient center in the last 2 years to the hospital because of hematuria or come back in clot retention. It's rare, fortunately, but I use Moses.
Lori stepped out. She does 3 days for all of her catheters. And then she has the patients take their own catheters out.
We do all voiding trials, like definitive, fill the bladder, take the catheter out.
Fill and pull, not a pull and hose.
Yeah, I definitely agree with everybody that, a lot of times it's like the social situation that determines whether you're going to keep them or not. And Mike and I send like probably 90% of them home at this point. And I think part of it is also like we have to get comfortable with the idea of sending them home. And what I tell my patients is, if you look perfect, I'm going to send you home. That's what I do. But if you don't look perfect, then I'm going to keep you. And so they're in a way they're kind of prepared for both. Generally speaking, I think part of the barrier of sending them home truly is actually probably not them, is probably our own comfort with it. You have to kind of get over that a little bit and just tell them, that, you're likely to go home. And they'll accept it too. Our patients are generally like very, very good about it. If you feel comfortable with it, they just sense it and they'll follow through.
Remember, it was 4% was our 30-day readmission.
That's pretty good. All right. Any questions from anybody that even topics we haven't covered?
2 questions. One is, I'm just curious how many people routinely cysto preoperatively, and then 2 is a guy who comes with no imaging, what is everyone's imaging of choice?
I do not routinely cysto unless I'm concerned about a urethral stricture, or if there's a really complicated, 3 KTPs, 2 TERPs, and a UroLift. Okay, I'm gonna look. But I don't routinely cysto. And if they don't have imaging, I try to do an in-office truss that day. So I've got a volume. Nobody goes to the OR without a volume. I think that's one thing that maybe we haven't talked about specifically, especially in your learning curve. You've got to know volumes. Like I have canceled proctoring trips because I'm very declarative. I'm like, how did you size their prostates? Oh, I'm pretty sure it's big. Nope, I'm not coming. I'm not, choose the situations for success, not failure. What do you do, Nicole? You cysto everybody, right?
I cysto everybody. And for the large prostates, I will never go on a transrectal ultrasound. I was telling Dr. Gilling, I got burned big time my first month in practice. I had a patient who came in with a truss that was 250 from the outside, and when we got to the operating room, I put the scope in, and I could only see the viru, and I was like, this is not 250. This thing is massive, and I don't know how big it is. And I had to do a perineal urethrostomy. I wasn't prepared to do it. I wasn't mentally prepared to do it, and I didn't have the equipment ready. Like, it was a big morass. And so all you have to do is be burned once, and it will change your. But a lot of these patients are coming with MRI because they have elevated PSA. I actually think that is the best imaging test. We are publishing, there's a paper in Press in the Journal of Endourology where we looked at the different modalities, and by far MRI allows you to predict your nucleated specimen weight, and telling you that your volume prediction is actually probably best with that. Not surprising.
To be clear, I don't trust other people's ultrasounds because one of my referring guys, I got burned. It was like, oh, it's 160 cc's, and our specimen was like 265. And it's a really bad day when you've got like an extra hour. Yeah, it's an hour and a half. Your time's wasted, right? So when I asked him, I'm like, how did you get that? He didn't know how to adjust the depth on his ultrasound, so he just measured from edge to edge of the beam. I'm like, I do not trust other people's ultrasounds.
Right. So Nicole, if someone comes in, you did a cysto, they didn't have an MRI, no trust, do you still get a size, or you just go with the cysto?
So on my learning curve always, I tell patients I can tell extra small, small, medium, large, extra large, and I usually can tell it in the retroflexion.
Okay.
And so if it's clearly a small gland, short prostate, I do not get cross-sectional imaging in that case.
I cysto everyone, and it's not just for the surprises part. I think it helps me counsel the patient. It lets them visualize like what is going on inside of them. So I'll show them the screen. I'll tell them what we're going to do, and I think it lets them process it a little bit more. I actually find it more helpful in that sense than the emergency. What am I getting myself into sense? And then just like Joel was saying, I get imaging of some sort on everyone. Usually a truss if they don't have anything else. And the truss volume, I'll usually add another 30% to it because I feel like it's just not as accurate. But yeah, that's what I do.
Yeah, so I like to have imaging, although at this point in time I don't feel like I need it before I do the case. But it's interesting in our system. If you come into the ER with urinary retention, you're going to get a CT scan. Yeah, so I find like a lot of my patients who are in retention, they've already been imaged. I agree completely with Nicole. Like I've had like other people do ultrasounds and they send you like what is the result. They can be way off. I remember like early on I did, one of my partner sent me something that he said was 95 grams. It turned out to be like 295 grams. Yeah, it was like way off. And so for the really big ones, especially when you're not sure you're going to be able to, if that's really in your size range, definitely I agree with Joel completely. You should know what you're getting into. Get some kind of imaging at the minimum, a truss. Yeah.
MRI is the best, but not every radiologist is Shane Wells. Last week I had an MRI where it was allegedly 300 grams. They measured from the top of the median lobe to the posterior aspect of the pubic symphysis. It was like 435 grams when I actually measured it. So, it's like anything gets pounded into us in residency. Look at your own images, do your own measurement.
Okay. Amelia has a question.
So you mentioned, sometimes a CT is already done. Do you get a truss or an MRI after that, or do you use the CT?
Not my favorite, but doable.
We moved to all transperineal biopsies in our clinic, so all we have is the biplanar probe. And I noticed that when I try to do trusses, often I can't see the base of the prostate, so I end up kind of guessing. It always makes me a little bit nervous, not knowing if they have, not knowing really how big the prostate is. But
Okay, Casey's going to come give some closing comments. I want to make sure I thank all the speakers for coming. I know this took time away. I really appreciate you coming and doing this for us, especially Peter, who came the furthest. And I wanted to thank all the participants for joining us today. And most importantly, I want to thank my partner, Mei Go, for helping us organize everything, and the staff, Maria and Ruth, who you all had contact with to get this all set up. So hand applause for all the support people. Thank you.
Thanks, John. So I don't have slides prepared for this, and we'll try to be brief here, but thank you again, Mady. This is a great venue. You do really tremendous work to support the Nesbit Society, and a really great weekend, and then another great time for you to join us at the AUA. We'll have to send you guys all an invite. You know, I think what I was struck by was the tone that was set in the very beginning by John Way. If I'm honest, I think I came to John with a bit of skepticism when he wanted to convert the entire department to HoLEP surgeons. But I do truly think that in listening to everybody speak here, both the participants, the speakers, and those that brought great questions, is that, to Adam's words, we do need to somehow bring this outside of the academic center. You know, there are places like, New York City where you can be within a mile of 7 or 8 different hospitals, but then there are areas like rural Michigan where if the only place that you can go is the University of Michigan, then you may really be out of luck and potentially get a suboptimal surgery. So I really took that to heart. And I think having speakers like Joel, and who's been doing it for quite a long time, and John Way, who's really made a mission of training residents, this not being necessarily a fellowship mandatory learning curve, is, I think, vital. And that's how we're going to take this outside of the academic centers, because not everyone is cut out to do a fellowship. It's time and it's energy that you may not want to spend to learn a technique. So those things really struck me. And then I guess the last little pieces of advice I'd have for those people that are picking it up is give yourself a little bit of grace, be patient with yourself. Joel, I think you really said it well. Some of these setbacks that you're having are not failures. They're really parts of the operation that you're learning that are going to go towards really making this something that you're going to be able to deliver to your patients. But seeing those setbacks as complete failures is really the wrong way to think about it. We wouldn't do that as residents, so why are you doing that? Give yourself a little bit of grace. The second thing is, and I'll start using this, I generally tell people 60 to 120 grams. I think your idea of 75 plus or minus 15 cc's, that's incredibly precise. We're gonna have to talk over a beer about how you arrived at that. But I think that's a really good thing. Set yourself up for success rather than getting yourself into a potential situation where you might have a setback, which we're not gonna call a failure. And then finally, what I would say, and I think Neil, you kind of tongue-in-cheek said it, I would have helped you if I thought you needed help. I was offended by that. Ask for help, even if it's a colleague who doesn't know how to do enucleation, right? Having a partner come in the room and say, like, have I jacked this up here? Am I in trouble here? Just getting another set of eyes in the situation is vital. And for those that are learning, recognize that you're coming at this not as a junior resident. You've done hundreds of transurethral surgeries along the way. You're better equipped than any resident to learn this operation as a practicing attending because of your experience with transurethral surgery. So ask for help, choose the right cases, and try to have fun with it. I think it's probably one of the most enriching things that I do is delivering this sort of an operation to patients. I think they, in general, do really well. I feel like a surgeon doing this operation, which is something as an endourologist who largely just pokes holes and stuff. And so have fun with it. And if we can help collectively, the collective we, please let us know. So thanks again, John, for putting on a great program. And thanks to our speakers.